position.
That's gonna happen.
Position and prepped here. Right? So,
Do you want a drape? Do we have a drape in there?
yeah, we do. I just wanted to say I'm prepping first here. So prepping. He's prepped.
Guys, I'll go over here so you can.
We're all gonna have this free video.
Like this. I'll stay in here, Kim. We'll show how to put the condom on and everything sterile. Okay.
So I'm going to open my kit.
Sterilely?
Here, I got it there. And now I'm going to get my gown. These gloves are sterile too. Not a lot of space.
Those are 6.
Yep.
I thought it was 5.5.
All right. So the 2 slots here. You're gonna put your hands in and kind of like flop it out a little bit like that. All right.
You can do that again.
Yep.
Calm down, Gabe.
I missed it.
So it's only 5.5. That's why you missed it.
I don't like this video now. He's got this video right in my face.
Oh, delete that. Start over.
All right, so I'm gonna do it the real way. Thumb down, fingers towards you. You're getting the other side of the glove here, this lip here, right? You're gonna catch it with your thumb inside here. You're gonna pull it over like that. Pull the sleeve back. I'm done. So this one now you can do it the regular ways if you're doing a spinal. I mean, you don't have to, I guess, but and then you're just gonna do it the normal way. If you can get it in. Alright, so now I'm ready to go. Now I can bring this whole kit over here if I want. This is all sterile when I
You want a Mayo stand or to make it more real or no?
I use this. We can move that though.
Because we got one in the same line.
Okay. So first thing I'm gonna do, we're already prepped here. We prepped before. So this says head this way. I actually do head that way. I think I've told you guys if you were in my lab before, because there's more coverage for me going this way. So now I lost it though. So you're gonna put the circle right over where your landmark is. Looks like it might be backwards. This is backwards. Upside down. Okay. Now I'm gonna come to my kit. Here, swandom. The wire. I always take this little piece off my wire and I'll pull the J-loop back like this, just so we can easily put it through the needle. Have that there. What's this called?
Tube manometry.
Tube manometry. Good. Then you got your central line here. You're gonna put the dilator through. If you have any clips in here, or the blue caps, you would put the blue cap on as well here. That's what I would do now, but you can do that at the end as well. I typically use this catheter, the plastic one. It's kind of like a long IV for my Finder one, but you can also use the steel needle as well. You got your needle, your knife.
What are you looking for?
Forceps or whatever for the needle. This might just be a.
Oh, yeah, this is, yeah, I think I took this from Cleveland Clinic and we don't use the forceps, we just use our hand.
So yeah.
We usually do a curved needle though.
Yeah, that's what I usually use. Anyway, this is the needle in the kit. It's like a suture needle. All right, so now what are we gonna be ready for? We're ready for. We have our stuff here. We have our patient prepped. Now we have the ultrasound. Our next step to do is the ultrasound swandom. This.
Probe cover.
Swandom is for the piece. Alright, so what we're gonna do is we're gonna put our hands up in here. This. You're gonna put a little bit of lube inside here, and then someone's gonna pass it to you, and you're gonna grab it, slide it over the top, like that. Try to get the air bubbles out, and then the rest of this lube you can put a little drop there. Alright. Very important that we know where medial is, right? So we want to check medial. There's lateral here. So medial is going to be on this side. And can you increase gain for me? There we go. Not the greatest picture. All right, so we got our carotid artery medial on the left side there. We got our jugular vein on the right side there, and we would know. How do we know?
It's compressible.
Compressible.
And
It's not an equally round shape like like the artery typically is, and it's usually bigger. Not always bigger, but usually bigger. All right.
Is this actually compressed? The compressed, right?
Yeah. This is not a great ultrasound picture. All right, so.
So pulsing is our artery.
Correct, yeah, so.
Usually-
Can you try to compress it?
Please do.
Yeah, it's compressing. See it compressing?
You see it compressing? And then you see, obviously, right next to it.
You want the artery again on the medial side of you, because when you're going in with your needle, you want to go ipsilateral. You want to go towards the same side of the neck. All right. When you're going in, you're going to go in at a pretty steep angle. You're going to put some negative pressure on the syringe, and you're going to go just about, I don't know, centimeter back, basically. A little bit of negative pressure.
There you go.
Okay, so I'm going to draw my angle a little bit. Very commonly, you're going to go in and through it, so you might have to come back on it. What I do is I will thread this in over that. But you don't always have to. You could just keep it there and go with the wire.
Do you have to hold your finger down?
Do I have to hold this down?
The finger over the lumen?
You don't have to.
Okay.
You can.
You leave the catheter in, right?
I leave the catheter in
see,
while I'm doing
I
the
always
needle.
do the other needle, yeah.
Yeah.
I don't do the catheter, but
Yeah.
it works.
But I don't know if it's working now.
I think on the dummy sometimes it's hard. It like
It's not going to thread as
It
far
won't
as it's
thread.
supposed to.
No, I don't think it will.
it'll
thread
go
super far.
through the
It's not threading at all.
This will?
if you try to feed it.
So just do it a little bit then?
See, it's not threading. So if it doesn't thread, it's actually a good little point here. So what you can do now is go back to your syringe, connect it here, and try to aspirate and pull back. There we go. See that?
Mm-hmm.
Now I'm going to try to keep it tight here. I'm going to go straight with my wire. It shouldn't feel like this. It should be pretty easy. If you guys ever run into resistance when you're doing this, stop. Kind of evaluate what's going on. So then we're out. Another way to check if the wire is in the jugular is to, you're gonna follow, see how I'm tilting towards the chest here? You're gonna watch it dive down into the chest. Which you can't really see, I guess, on this one, but that's another way to do it.
Are we in?
And this ultrasound is not helping me.
I think I see it.
that not
Isn't
it?
it
Is
not
that in the
in the
vessel though?
vessel?
I don't, yeah.
Yeah, it's on the top.
It's weird how it's longitudinal.
That doesn't make sense. We're just gonna go through this anyway. So that's in now. What I normally would do here is I'll load my line on before I get my knife ready. So I'm gonna take my knife, I'm gonna put it out most of the way here. My 4x4s I will usually keep right here, and I'm also gonna wipe the lube off. At this point I'm gonna spread the skin out a little bit, and I'm gonna have my knife tip up, and I'm gonna be on the right side of this wire, and I'm gonna go in about, I don't know, halfway down on this roughly. It's gonna start bleeding, so that's why I have it preloaded, so once I put this in, it's gonna stop bleeding right away. And you're gonna go in 2 pops typically, 1, 2. And then once you get this part, you're gonna hold the wire. See, I'm pulling here, and the black part at one piece, you're gonna slide it in and pull it out.
Just as another note on this, so he's getting ready. He's going to be putting in a PA catheter, right? So not all central lines are going to have this big, thick piece, just so you know, that's quite like this. And so you do have to push that in pretty hard. If you are going to be doing any cardiac, you'll be pushing that in hard, and it's going to feel very uncomfortable. And in the words of one of my Russian attendings, which is very inappropriate, she loves to tell everyone, do not be a P word.
For the record.
So through that, you only really had control of the wire when you were doing the final advancing. That's fine.
I'm sorry, what do you mean?
Like the wire was just kind of in them and you weren't holding on to it.
Right, I'm not, the wire's not, I mean, you leave 2 feet out of the wire. I'm not holding on to the wire at all times. It's not
Okay.
going in.
The wire's pretty long.
Yeah.
Because it has to cover all this more into the vessel and then out, like it's a long wire.
Okay.
Yeah, you can see how long it's there.
We can pull it apart. Oh, you already did it, yeah.
So yeah, so the wire hanging out here is okay, totally okay.
Okay.
with that. And then this is just guiding over the wire now, right? So at this point in time, I would negative aspirate these ports, put my clip on, whatever. I might pass a line off so somebody has automatic, or someone has access to the central line if they need to get drugs or anything while we're doing this other part.
Where's that PAC?
I'm also at this point going to, now I'm gonna suture this in. And I would prefer to instrument tie. I'm not a good hand tire. I look like an idiot doing it. But so, sutured in, assume it's sutured in now. Now you're gonna have somebody with the PAC, they're going to do this exact part for you. First thing you're gonna do when you're grabbing, this side first. I'm gonna grab the tip here first, okay? And then we take it out, and then go. So he's gonna take that syringe now, and make sure you're not lifting it too high, because I've done that and I hit like the light or something. So keep it.
Or the lights right there, is that
Right,
what you said?
yeah. It happens all the time. Not all the time, but it happens. So,
100%.
so he's going to test the balloon.
So everyone's gonna look right here. This is a preset syringe that comes with the kit.
It only allows you to do 1.5 cc, so it won't even let you come back.
So I'm gonna take it off here. And
Exactly.
it's gonna deflate.
And he did not deflate it himself. He took it off to watch it naturally deflate.
Everyone see that?
Okay?
Okay.
So next thing he's gonna do is he's gonna connect all of our ports here. And he's gonna flush them. We're gonna prime the line. So I'm gonna say, all right, flush PA. He's gonna flush PA. He's gonna shoot out the front here. Then we'll say, all right, flush GVP. He's gonna flush GVP blue. He's gonna go out here or wherever the hole is, right here. Then all right, flush VIP. He's gonna flush VIP, the white line. And it's gonna be the top. VIP, does anyone know what that stands for?
Something
Vasoactive infusion. Vasoactive infusion. Good job. All right. So
And you should know how far along the PA catheter each of these are, just that part.
So now that we have that stuff down, it's time for the swab done. Now is this a continuous cardiac output or not?
Yes, because
How
it
do you know?
it has the
Thermal port or the thermal.
Exactly.
thingies on it,
Thermistor there, or whatever they call it, thermal.
coils or something.
Coils, yeah.
All right, so when you're loading this in, you're gonna load it back. I keep it together like this to make it easier. Then I'm gonna grab it, I'm gonna slide it all the way back. I'm gonna come back, and I'm gonna lock it. It's a weird lock.
Is that this one?
This is
This
the
is
swan.
a swan dome, yeah.
And then I'll break it here. That's just what I mean by break it. Just so when I'm connected to the patient, I'm not like jabbing at it to pull it through.
And by locking, he just kind of screws it and tightens it up onto this here.
Yeah, this won't move now.
And now with this one, he'll show you, there's a special locking mechanism right here.
So when you go in, you kind of want to keep this coil here, like this, when you're going in. And they always tell me I've always been taught to go in at 11 o'clock with this. So if this is 12, it says it's 11, and you want it facing kind of down here. So I always will go in like this, roughly. And then I'm going to go in. When I get to the coil, that's when I say balloon up, right? So he's gonna put balloon up, and that's gonna do what? It's gonna help float it in, right? So as the balloon's up, I'm watching the EKG, and it's gonna be wherever it is, and I'm advancing 1 centimeter at a time, roughly, depending how far in I am, with the heartbeat. So it's beep, 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 right? And then you're gonna see you're in the RV. Then you're gonna see now I'm in the PA. How do we know we're in the PA? Diastolic step up. All right. And what's the waveform shape of the PA? Is it trending up or is it trending down when we're in the PA and not the RV? I'm talking on the downs when we already get the peak of the PA waveform. After that peak. Yeah, but I want at the whole time, if you're in the PA, you're always having the downward slope. If there's any little upward slope before you get to the peak again, you're not quite far enough. You got to keep advancing a little bit. There's always going to be trending down. Okay. So I get the diastolic step up. I see it. I advance like 1 centimeter more, and I'm done. I will then take this part here. You can see how this is kind of like a little locking mechanism. This actually has two locking mechanisms. It locks on to the port itself, and I just twist it, and then you would twist this one too, but this one might not have that actually. So then there would be a second one here that you would twist that's gonna hold it onto this, and the whole thing's gonna be held onto that.
This one just has the one.
Yeah. So at this point we're done, right? Taking this off. I'm gonna rip this. Stuff out of here. So I'm gonna take this out of here. Get a take it in.
Not the good ticket.
And we're gonna put actually there was
Oh, we have I brought one of these here. We don't have the fancy. You guys use the fancy ticketer?
Yeah. So this is gonna go on now. So I'm gonna check all of this, I guess, whatever. So we're gonna put this up, blue to the sky. You go like that, okay? Then you're gonna throw a tegaderm on top of it, and you're done. Okay.
Where are the sutures?
Sutures were in. I just didn't do it.
We can't suture on
Implied sutures.
this right here. But you see this part? This is where you would suture those two holes right here on the
Okay.
central.
So I'll show you. I'm not gonna poke it, but I'm gonna go in the skin here and out and like in and out real
So
quick.
you would
and
do
then
that sterilely, is that what you said?
Yeah.
You would
This
do
is
it all sterilely.
all sterilely. And then you're gonna pull it through, and depending on how you want to do it, you can tie it with your hand. You do the same thing on the other side as well.
Okay.
That was before
And
we
then-
did the PA catheter.
And then tegaderm over all of it?
Yeah.
Tegaderm over everything.
Okay.
Yeah, get it sutured in.
And then
What'd you say?
confirmation, now they're bringing in an x-ray to confirm, or
Yeah.
nothing for depth or anything?
Any preset.
No?
Oh,
Okay.
Well,
Do that
no
in
one's gonna be paying
ICU.
attention to
Yes,
you.
you- okay.
Not gonna do that unless there's like something you're doing.
First time I intubated, there was like
Okay.
a
Does it have a
resident somewhere
dilator
watching me,
on
like, you gotta
the
get it.
liver?
Although I will say,
'Cause you pulled
I've had
something out, it
cardiac
looked like a
surgeons that
dilator.
were
Yeah, this is a
very-
dilator.
He
Oh.
loaded it himself.
Oh,
Yeah.
I don't know if that's the right word, but
Where was
like
the diet?
covering.
It was this
And
thing,
so
right?
I-
This is
we
the
put it in
Okay.
the
Did you
right
have
place, and
the
you put
dilator
in
up to the
intubate,
skin
they
when
see
you
me
cut?
Do the central
Yeah, I had-
PAC,
so I
Like
had-
protecting the
the
wire.
whole time watching
No,
the
it's not
CT.
actually for that.
Okay.
It's for when I make the cut, I'm gonna advance this right away, so it just decreases the blood loss and makes it a little bit prettier. It's not really necessary. A lot of people don't do it. Only one doctor showed me, and like, actually, I kind of like that. It makes sense. So I load this on the wire before I make the cut.
Okay.
Most people will make the cut and then load this on the wire.
Okay.
it's still 15 to 18 with the wire, or what was it?
Yeah.
One thing I just want to clarify, and I know you know this thing, you just got tongue tied. He had mentioned watch the EKG when you're floating the swan. This should already be hooked up to the PA pressures at that point, and that's what you're going to be watching.
Okay.
Yeah.
Do we flush all the ports before we insert it too? Like,
Yeah, that's what I
That's-
said.
yes, yes.
no, but
Flush.
not just for this. Like,
For the central line as well.
So yeah, so after I did this, I said now I would take the syringe and I would aspirate and put the blue cap on. Aspirate and put the blue cap
or would
on.
you flush
Oh, you mean
before
flush
get
before,
insert?
like
Yeah.
after you open the kit? Some
Yeah.
people do, but
Some
not
people
everyone
do.
does.
Okay.
yeah.
But you don't have to as long as you make sure you aspirate.
Correct,
Yes.
Okay.
Don't push in the air, but yeah.
Right.
That's why some people just get it out of the way and get it done.
It depends if, like, some kits will come with these the blue claves.
The micro
And if you have the claves on there already, then yeah, people will just do it. But if it takes like an extra step and they gotta go get it, a lot of times we just do that after. We'll
Okay.
aspirate and then flush it with saline after.
Our
Okay.
anesthesia techs, for our J loops, we can take off the whatever it's called, and they just open them up, put them in there for us, so we can just put them on flush. That's what we want to do.
Right.
Yeah. So it's pretty nice.
Yeah. So yeah, then at that point, if you have the PA in, and this is your setup, and you're doing hard, what we normally do is you get your PA pressures with the blue, right? You get your CVP pressures with the blue. You get your PA pressures with the yellow. We use this white for all of our infusions, the VIP stuff. So I still have two big lumens here, and all my like basic infusions are coming through here. Like our setup, so if we had a manifold here with Levo and FD and all this different stuff, it's coming through here and dropping in that way. And that way, if I needed to give blood or I needed to give anything else, I have
Those are
these
like
other two
emergency
You
ports,
can
basically.
still use the CVP ports even though you have the PA catheter. Like you can still hook something up to those two.
Yeah.
Yeah.
For sure.
Okay. Oh yeah.
Totally.
Yellow's distal.
Yellow's the tip. Yeah.
PA is right at the end of the catheter, right? CVP's in the middle, and then VIP's proximal.
Would you ever exchange the central line after the case to if they're going to ICU or something, or would keep?
No, that's gonna be a discussion that gets made before the case. So what kind of central line do we want for recovery? And if it doesn't make sense to have that central line for the case itself, then you would. But I've never really seen that happen. That's a discussion with the surgeon though, and what kind of things he's gonna need for afterwards.
If that's a bad central line, and there's no reason to take it out unless it's been in there a long time, it's growing vegetation, or it doesn't work. So if it doesn't work, you're not exchanging it, you're taking it out and putting in a new one to be able to have.
Okay.
So the port attached, not the port, the electronic attachment to the yellow is for your PA pressures. The one with the red on the end.
These have to do with the cardiac output.
Yeah.
Oh, that both.
Like you're gonna plug these into.
Distal.
I forget exactly which one's doing which.
I do too, and we don't have anything to show us to hook it up.
But one's
Okay.
gonna be for the thermistor, and
Yep.
one's gonna be for
And you're not gonna ask us like
the other.
The PA pressure? Which one's the PA pressure?
Just
Measuring
when it
the
comes
PA
to
pressure-
anything
PA pressure's
from the
gonna
book,
be-
the lecture, the PowerPoint.
The PA pressure's actually gonna be through the same transducer that our line would be.
Oh, so it's just measuring the pressure through that, okay.
It's an RLN transducer.
So, okay, and then what's the blue one connected to there?
I would say each year we do more.
I think it's just part of measuring the cardiac output.
Okay, so all three of those would just be more electronic.
Yeah. It's all electronic stuff. And there's no way you can really mess it up because they're different sizes.
Oh, okay.
This one won't fit into this one and vice versa. And same with this. It's a very unique shape that can only go in one way into one thing.
Gotcha. Okay.
That's true. You'll still be a
Figured
second
them down.
Good to go.
Does anybody have any other
As a
questions
matter of
about
fact, like
this?
in Australia and New Zealand, they just do it under like local. They just gargle a little bit and they don't do any.
Every